do you understand the importance of time and range, how should you think about the problem if the time and range is less than 70%? The first thing to consider is there a problem with hyper or hypoglycemia? We define hyperglycemia in this case as a time above range of greater than 25%, and that can be identified on your AGP. We define hypoglycemia as a problem if your time below range is less than 4%. So first, we're going to think about one of these two problems and then look at how we can address that. Once you've identified that there is a problem with hyperglycemia, that is a time above range of greater than 25%, the first question to ask is the patient consistent with the regimen? Are they performing the regimen that you have prescribed to them? Maybe if not, there are barriers to that you can address, such as helping them get their medication or getting their insulin, or maybe clarifying exactly how to do that. Once you've identified those barriers, the next thing to look at is there a pattern to the hyperglycemia? With the CGM, you'll be able to see both time of day and also days of the week. Identify if there are certain lifestyle factors that are playing a role in that hyperglycemic pattern, and maybe something you can address with the patient. After you've looked at this, you then want to ask the question, is the regimen that we've prescribed adequate? If not, you may seek to increase that regimen with non-insulin therapies such as SGLT2s or GLP-1s. If a patient is already on these therapies, then maybe it's time to add prandial insulin to the regimen to get better postprandial control. Last but not least, if a patient is already on basal bolus therapy, you may need to augment that therapy and adjust their insulin doses, particularly by increasing their insulin dose at mealtime or administering something more specific like an insulin to carb ratio in calculating that insulin dose. If you've identified that there's a problem with hypoglycemia, that is a time below range greater than 4%, the first question to ask is, are they on insulin therapy or non-insulin therapy alone? If they're on non-insulin therapies, they're most likely on things like sulfonylureas or glutamides, as these tend to cause hypoglycemia. So you may want to look at reducing the dose of these medications or having the patient eat more frequent meals and space those meals out consistently to avoid hypoglycemia. Now, if the patient is on insulin, you want to identify whether they're on basal insulin alone or a basal bolus regimen. If they're on basal insulin, you want to make sure that they're not over-basalized. We typically define that as a dose of greater than 0.5 units per kilo per day. So if they are over that dose, roughly 50 units or greater, then you probably want to reduce that dose, and then you can address any hyperglycemia that may occur with other medications. Finally, if they're on a basal bolus regimen, then you want to make sure first that their insulin is in balance. What we mean by that is they want to be roughly 50-50 basal to bolus in terms of their total insulin per day. Once you've identified that they're roughly in balance, you also want to make sure that their timing is good. That is, that they're taking their insulin prior to their meal. If they're taking their insulin during or after a meal, it's likely going to cause late hypoglycemia, and that can be something that can be addressed. Finally, if they are taking their insulin consistently and on time, then it may mean that their insulin dose is just not correct. So make sure that they're using an insulin to carb ratio, make sure that they're counting their carbohydrates correctly, and if they're doing those things, then you want to also make sure that that insulin to carb ratio is correct. So you may want to adjust that to make sure that they're getting a little bit less mealtime insulin to prevent hypoglycemia. If you've identified that the patient has both a hypo and hyperglycemia problem, which is that their time below range is greater than 4% and their time above range is greater than 25%, my recommendation would be to address the hypoglycemia first. The rationale for this is really twofold. One is hypoglycemia generally is more dangerous than hyperglycemia. And two, hypoglycemia can often lead patients to have rebound hyperglycemia. So maybe some of the hyperglycemia that we're seeing with these patients is because they're having hypoglycemia first. So address the hypoglycemia as we've discussed, and then you can move on to the hyperglycemic problem. For more information, visit the American Diabetes Association's Time and Range website at professional.diabetes.org/time and range.